Hi everyone, good morning, good afternoon, good evening from anywhere in the world you are joining us. We're so glad to have you on this very important discourse, and we hope that at the end of today's webinar, it will be worthwhile. And for many of us who joined, this is a webinar series that fits into the interdisciplinary group on population health. And we are working with them to have this session. To begin with, I would like to introduce myself. My name is Odey, and I would also like to share my positionality. I am from Yala local government in Nigeria, and Yala is a small minority group. For those of you who know Nigeria as a country, Yala is a small minority group. Also, I am currently doing my master's in health policy planning and financing at the London School of Hygiene and Tropical Medicine and London School of Economics and Political Science, which is a joint master's program. I began my studies in Nigeria. I had my bachelor's in public health at the University of Calabar, and my educational trajectory has been based on the influence and support of my family. And then for my master's program, I'm a recipient of the Achievement Scholarship, which is a scholarship that is facilitated through the Commonwealth partnership between Nigeria and the UK government. Now, these bearings, in a way, impacts on who I am. Nigeria as a country, which was colonized by the British over 60 years ago, and my engagement in the sexual and reproductive space in the last 6 years. I have been deeply vested in it from a personal experience of how family planning, access to reproductive health services has shaped my life, from my mother, who has her own story and brought us into all of it. At the same time, through my engagement on programs, public health programs and projects, I have also seen the power dynamics on who decides the agenda when it comes to programs and projects, and how these are implemented in line with what are the felt needs of the community and what is the reporting mechanism and the accountability that comes in between. And in my growing career, I have asked questions on why are we doing this and what is the long-term and short-term goal? How do we sustain this impact? And how do we ensure that it is equitable? So all of this led to my current engagement as a co-chair of the International Conference on Family Planning, particularly the power shifting for Global Health Equity Subcommittee, which I'm currently affiliated with. And I've been involved with the team facilitating and pushing conversations to challenge the status quo, to call out these power structures, the impacts, and more importantly, to drive individuals and institutions to commit to sharing and shifting power and to enhance equitable engagement across global public health sphere. So that's more like an introduction from my end, and I'm so glad to be here. So to also get us into this conversation, for many of us, I am wondering what was your point of interest to join this webinar. When I shared it last night with my circle, a few persons were like, goodness, what is power shifting? And some people who understood what power shifting is were like, I'm interested to see how this intersects with the work I do as a researcher, as an activist, and for some people, they were interested to actually hear what our amazing speakers have to share in the context of how the history around population health and the dynamics what we are looking forward to in terms of advancing equitable engagement in population health. So what would it be for you? In a few seconds, we will be sharing a link to the exam board for you to share what is power. So it doesn't have to be maybe a dictionary definition or Wikipedia definition. You can just share in your own words. What is power? We just have like a second to respond to this. So if you would like to just share with us what is power. Agency, beautiful. Influence, I like the phrase. It helps us to just get on it immediately. Autonomy. Autonomy is coming up again. Thank you. Control. Control. Decision making. Epistemic authority. This is even more descriptive. Control of decisions. Thank you. Not hearing no. Okay. I think we are getting a lot of contextual definitions. Agency is coming again. Sit at the table. I agree. The feminist in me is saying yes. Often associated with money. Very true. Okay, we've gotten really amazing response. And I also have like 2 more questions coming up. I see that power is a voice. Thank you. My colleague is going to share another question which we have for you to respond to say, now you have defined power as you understand it. Who has it? So who has power to the best of your understanding? Again, it doesn't have to be anything technical. As you understand it, just share with us. Thank you. So who has this power you have described? Money. Yeah. It depends on the moment. Yeah, I agree with you. It's relative in some instance. Funders, absolutely. Anyone making decision makers, yeah, very true. So we see like many of us are aligning in our thought process and in our definition of power, who has power, anyone involved in the struggle for liberation, that is power to the people, the elites, I agree with you, institutions, money, people with privilege, I agree. Anyone involved, okay, I think I've had anyone involved in the struggle for liberation, people working together, so the power of synergy. White, cis, heterosexual men, yes, that's valid. Administrators and supervisors, politicians, donors, INGOs, funders, world institutions, those who can speak and be heard, anyone making decisions, brilliant, billionaires. Thank you so much for this amazing response. Wealthy institutions and governments. We have one last question, and this is going to connect to what is power to you, who has it, and in your own sphere of influence, in your own field, the work you do, your engagement or your community as the case may be, how does this impact your work? How does this definition of power, who has it, how does it impact your work? I'm really looking forward to your response. We must always be responsive to those in power, I agree. Determines what research questions are asked. Yeah, when we go more in depth, that will give more clarity. In sociology, it's our duty to speak truth to power. True. So I see that someone is saying frames, that power frames the priorities, ideologies, and biases. It determines whose voice is heard and valued. So in terms of the impact, it impacts who gets funding. It impacts the need to obey to get funds. It restricts our ability to be innovative and try things that might not work. It shapes programs and priorities, monitoring and evaluation. Power imbalances creates inequality. We study inequality to make the world a better place. I agree with you. Working within structural constraints. It determines those whose voice is heard and valued. It determines whose voice is... Okay, we must always be responsive to power. I think we have made a lot of progress. Drives who we see as key audience and messages, prevents truly effective research and sustainable programs. So these are really amazing feedback we've gotten, and I absolutely appreciate you. And this is an amazing way for us to just dive into today's conversation on what is the background behind these power dynamics, these power relations as it relates to population health. And we are so lucky to have two inspiring and amazing speakers who have been walking the talk when it comes to shifting power and advancing equity in population health. I'll be handing over the mic to them in a second, but I'd like us to just get a brief overview of what we are looking at today. So today, this webinar is one of two series. And for this series, the focus would be on the history of family planning, reproductive health, and what are the weights attached to it. At the same time, we want to get a sense of how these historical legacies has impacted population health and development broadly, and how they impact the systems that we are currently working with and within today. So with that, I'm going to invite my speakers to share with us, briefly introduce themselves and their positionality. I'll begin with Dr. Vincenza Mazzeo.
Hi, everyone. It's a pleasure to be here today. My name is Vincenza. I'm currently a Ph.D. candidate in the Department of History at Johns Hopkins University. I work specifically on African history. I'm also a fellow at the Center for Medical Humanities at Johns Hopkins University and a fellow at the Alexander Graf Humanities Institute. I am Canadian-Italian. I'm currently in the U.S., in Baltimore, which is unceded territory of multiple indigenous communities, including the Piscataway people. So I'd like to acknowledge unceded territory and how we use space at intellectual institutions in the US and on a global scale. And I'm glad to be here today. Much of my motivation for studying the history of health broadly put comes from experiences through the patient-doctor paradigm. At a very young age, I thought I would be a medical doctor, and I quickly started to see how bodies in the field of medicine were not only gendered and racialized, but I wanted to understand how that limited healthcare. So I dove into medical history as a way to begin to answer some of these questions. And you'll see that today's presentation is largely influenced by my training, but most importantly, tries to understand all of the conditions which create some of the problems around structural violence that we see not only in healthcare, but in society more broadly put. So for today's presentation, I'll be talking about histories of population control programs from the global to local spaces. And specifically, South Africa will be the case study that I use to talk about how these forces materialize. Next slide. So to give you a quick sense of where this presentation is headed, I wanted to give you a short agenda. We'll go through 3 sections. The first will be foundational concepts. The second will be a brief history of population control. And the third will dive into the case study of South Africa. So before we really begin, I want to walk us through some of these definitions, in part because I'm unaware of the makeup of today's audience. I'm sure many of you are brilliant, but I want to make sure we're on the same page when discussing these concepts. So population health, and I'll go over this fairly quickly, assuming that many of you are aware, is defined within health histories as both a concept and approach. And for many of us, the concept is about health outcomes of a group of individuals, including the distribution of outcomes within that said group. And that group is broadly or closely defined. It can be a nation, a community of people, or category of persons. But I want to talk about it throughout this presentation as an approach, and that is a kind of unifying force or a way that we think about an entire spectrum of health services and related services and interactions between them that aren't limited just to the prevention and promotion of health, treatment and care, but are very much about different approaches to improving population health overall. And I also want to note, as I go through the talk, that what we call population health and the population health approach takes a very different shape with divergent outcomes where private and public healthcare exist, and often where these two models compete. So we'll return to this conceptualization later on. Population control, you'll typically see this referred to in some parts of the world as human population planning. This term denotes generally a practice of managing the growth rate of a human population. In theory, the practice of population control is intended to increase or decrease the overall population growth rate. But historically, the practice of population control or population planning by governments as an explicit on-policy or on-paper policy is fairly recent and is very much part of the making of the modern nation state. And I think this is something we miss when we talk about population control. Part of that relates to eugenics. So eugenics as a contemporary project sought to control the human population through the practice of selective reproduction. In the late 19th and 20th century, eugenics, and specifically negative eugenics, that's the reduction of growth rates, played a central role in how specifically British and French Empire governed their colonies across the African continent. And it's within this kind of historical context that population health and family planning emerge as political goals and mandates under the guise of development and modernity. For many women, not just women in the global South, scientific medicine is deeply entangled with the emergence of these projects and specifically with family planning. This includes forced sterilization through tubal ligation, hysterectomy, Depo-Provera, and IUDs. So the fourth concept that I want to talk a little bit about seems fairly simple, right? Africa as a continent. But in the global north, I believe many of us are situated somewhere either across Europe, Canada, or the United States. There are at least two dominant ways of invoking this term, and both are related whether or not we're cognizant of it. First, we think about the African continent as a geographical place, right? Whose present borders were designed through the Scramble for Africa by European countries and the Berlin Conference of 1884. This is the conference at which European powers decided how they would develop a regulatory framework for the colonization of the African continent without entering into conflict amongst themselves. Between 1650 and 1914, about 90% of the continent was under formal European control, with the French and the British controlling vast regions of the continent. The British governed over most of Southern Africa and the French over most of West Africa. You'll see in these two maps that there's a modern map of the continent of Africa now and an earlier map which denotes how the continent was colonized. So through this period and up until the 1960s, people living across the continent were subject to several processes of colonization. And I want to walk us through these quickly, just to make sure that everyone has a sense of the various tentacles of this kind of process. The first included land removals. The second, the introduction of foreign or colonial governments through either indirect or direct rule. This included legal frameworks and taxation. The third is the replacement of language, culture, and customs. And the fourth is new formations of direct and indirect violence. And this can be from physical state-sanctioned violence to structural violence, of which family planning projects have been a part. Anti-colonial movements often targeted these processes, and independent African nations sought to reestablish familiar forms of governance while celebrating their future as a sovereign actor in a global world. For many, this work continues. Second, and this will be somewhat dissimilar from what many of you know, the term denotes a singular space devoid, allegedly, of a long and dynamic history of trade, ethno-linguistic development, political formations, socioeconomic customs rooted in generation, and knowledge production, specifically about health, healing, and medicine. What Mundimbe calls the invention of Africa in his book by the same name demonstrates how the production of myths regarding the continent were central to its making in the European imaginary and were motivated in public discourse to justify colonialism. For those of us interested in working on decolonizing health, a reckoning with these histories and myths are necessary to not only dismantle the stereotypes that have been fundamental to the production of family planning, but persist in biomedicine and family planning initiatives today. So we're moving into the second section of this talk, which is a brief history of population control. For this talk, I'll begin with Margaret Sanger, who was a women's health nurse, or a nurse in women's healthcare, and she traveled between Europe and the US advocating for women's right to use birth control in the early 1900s. In 1921, she founded the American Birth Control League, which then became what most of us know as Planned Parenthood Federation of America. And while in India, she co-founded the International Planned Parenthood Federation in 1952. While this particular federation is now based in London and addresses women's health broadly put, Sanger's legacy for the Global South has its roots in her earlier work, which became fundamental and foundational to the development of family planning through intergovernmental organizations. First, Sanger argued in favor of negative eugenics. She claimed that, begin quote, more children from fit and less from unfit families was a chief issue of birth control. Her book, The Pivot of Civilization, read widely in Britain and the US, drew on Malthusian theory to suggest that population control and negative eugenics offered the only solution to prevent the growth of what she called degenerative messes. Second, Sanger, in what Professor Betsy Hartman calls a turn to respectability, supported doctors' demands for legislation which would guarantee their exclusive rights to prescribe contraceptives once they emerged in the form of a pill. While women were divided on how this birth control movement should proceed, Sanger built professional networks across Europe, the US, and by the 1950s, India and South Africa. By her death in 1966, she was represented as a leading figure in population control programming. With the end of the Second World War and the emergence of the US as a new global power, a familiar concern over population growth abroad rematerialized, with a need for raw materials for American industry specifically, the looming independence of African nations beyond 1960, and population growth across the Global South. Organizations and foundations took population control discourses under their guise and control. By 1970, the U.S. Agency for International Development devoted itself to specific forms of population control planning in the developing world. It's against this backdrop that the population establishment, as defined by Hartman and spoken about Hartman, emerges on a global scale with billions in funding from the U.S. and millions from across Europe. Made up of the World Bank, USAID, and the UN Fund for Population Activities, the population establishment collectively controls the flow of international funds to developing countries based on foreign agendas and narrow population programs rooted in American ideals. Historians of Africa commonly refer to this as neo-colonial programs or ideology. The World Bank, a significant actor across Africa, has also become a key player in population control programming. As a debt and loan entity under the guise of development assistance, the World Bank sought to pressure newly independent countries to enact population control programming, to access development financing. Loans then became contingent upon the adoption of population control as a path to development. Many countries, including Zimbabwe and Kenya, have argued against these policies, but incurred debt, which often then required additional debt financing from the World Bank. Put differently, a cycle of debt and debt repayment repeats itself. In addition, as Mark Eprick, a historian of Africa, points out, the World Bank often provided loans which redirected or directed healthcare expenditures. Funding assistance, for example, of urban hospitals in Zimbabwe was contingent on the introduction of private medicine through service fees, which users could not afford. Mark Eprick shows that where structural adjustment programs existed, a dramatic decline in hospital and clinic visits followed, especially for pre- and antenatal care and delivery. In the third part of this talk, I'd like to dive into what I call the paradox of South Africa. South Africa is, I believe, a paradoxical case study for women's reproductive rights. At present, it boasts one of the world's most capacious constitutional rights to healthcare, which includes both contraception and abortion. South Africa's 1996 Choice on Termination of Pregnancy Act permits girls above the age of 12 to procure an abortion without consent and demands that healthcare be both accessible and affordable, or put differently, publicly funded and free, so no out-of-pocket cost. Its history, however, is defined by divergent population control programs and by the early 1900s, the problem of illegal or clandestine abortion. So how did we get here? In Southern Africa, European settlement began in 1652 with the arrival of the Dutch East India Company in what we currently know as Cape Town. As the Dutch and British built colonies, they implemented Roman Dutch laws which criminalized abortion unless, in some cases, deemed medically necessary. These laws persisted through the formation of South Africa in 1910 to the election of the National Party in 1948 and the creation of what we call the apartheid state. This is a state that believed in the segregation of white settlers who were South African and Black South Africans. It's very much a structure of apartheid that relied on formal means of segregation. Before the arrival of Europeans, Catherine Burns suggests that oral histories demonstrate that midwives performed abortions and that women used herbalists to procure contraception. According to Suzanne Clausen, a historian of South African gender, the governance of women's bodies, sexuality, and fertility was of central and key importance to the maintenance and creation of the apartheid state. Within 2 years following its election, the National Party criminalized mixed marriages and passed the Immortality Act, which forbade sex between whites and all other races, and that's in quotations. The state, to increase its white population, generally denied white women the right to control their own reproduction. However, in 1938, it created subsidized birth control clinics, which sought to selectively curb the population growth of poor whites only. While these clinics were limited in size, scope, and users, by the 1970s, illegal abortions were described in South Africa as a social epidemic, with an estimated 250,000 South African women undergoing illegal abortions, the majority of whom were Black South African women. In response, an array of actions materialized. In 1974, the National Party placed what was called a gag order on hospitals to end medical reporting on unsafe abortions in an attempt to curb criticism of its population control program. Its Department of Health also sought to limit population growth by providing Black women with contraceptives under the guise of family planning. In part, and due to doubts over its safety, Depo-Provera was introduced to South Africa and India earlier than Europe and the US. What resulted is still an unknown number of African girls and women being injected with Depo-Provera without their consent or knowledge. In the early 1970s, June Cope formed the Abortion Reform Action Group in South Africa, but select members argued for the compulsory sterilization of poor, and specifically poor illiterate African women. Despite this dizzying array of population control programs and projects, Catherine Burns estimates that over 50% of women living in urban cities like Johannesburg use some form of contraception despite the policies. By 1994, South Africa had a higher density of contraceptive services than anywhere else in the world. In this way, South Africa's transition to democracy and support for reproductive rights with the election of Nelson Mandela and the African National Congress is not entirely unexpected. In recognition that anti-colonialism required the establishment of bodily autonomy and the rights of a person for Black South African women, reproductive rights were enshrined into law. In addition, and based on these histories of coercive family planning through Depo-Provera and the Delcon IUD, which was also used in South Africa during the same time and led to many women dying, the post-apartheid government approached foreign lenders and agency with much caution. In conclusion, my research suggests that biomedicine and global health projects must rethink the premise through which they operate, their funding sources, and how they interact with and encounter biomedicine, women, patients, and Indigenous forms of medical knowledge and practice. Undoing all forms of structural violence must be foundational to any work surrounding population health. And I think South Africa is an interesting case in which these things happen simultaneously. Thank you very much.
Excellent. Thank you so much for sharing with us, Dr. Vincenza. And I want to believe that for many of us who are part of this discussion, and maybe from Africa or South Africa, we can lean in on this history and appreciate where we are coming from and the current status of things. This takes us on a very nice momentum to hear from our second speaker, Dr. Annabel Sowemimo. I will be inviting her to introduce herself and also get into her presentation. Please take note of all your questions and maybe some comments you want to share with us. And after the presentation of our second speaker, we will give room for questions, comments, and reactions. Thank you.
Thank you very much for the introduction. Can you hear me? Yeah. So I'll just share my slides. So I think this links really well to Vinny's presentation. So I'm going to be talking to you today about family planning programs, and we've heard terminology changes, and this is another kind of theme that we need to think about why we're changing terminology in this sector in historical context, including colonial legacies and implications for decolonisation. And hopefully in the questions we can think about the appropriateness of what we mean by decolonisation as well. So I'm Dr. Annabel Sowemimo. I'm a community sexual and reproductive health registrar based in the UK, specifically in Leicester, but I'll be going off to my consultant job in London in a few months, which is quite exciting. I'm also author of the book Divided Racism, Medicine, Why We Need to Decolonise Healthcare. And I'm also a Ph.D. candidate at King's College London and a Harold Moody Scholar. I founded Reproductive Justice Initiative, which was previously called Decolonising Contraception Collective, about 6 or 7 years ago now. And that was very much at the start looking at the colonial legacies and how communities felt about the implementation of particularly reproductive health measures. And now our work is much more broad. So I'm going to just, I know some people like objectives, they like structured learning. So basic understanding of the relationality to colonialism to healthcare, understand alternative approaches, including reproductive justice frameworks, because I think can't really have this conversation and not talk about reproductive justice, understand criticisms. Vinny's already touched on this about Malthusianism and how it applies to our sector. Examples of colonial and neo-colonial practice, both in the global north and south. Try to broaden it, but I do talk about my own specific context, Britain, and how that relates more globally and how to utilise or apply these frameworks more widely. So just a bit about myself. So I trained at University College London, which has really been quite instrumental to my journey in terms of how I started talking about this topic and even how I really came to work in this sector. So that's where I did my undergraduate medical degree. And in the UK, we go to medical school at 18 and we go for 6 years. For some of us, I spent a year out intercalating with medical anthropology. Now, UCL was founded in 1826, and we're really told to celebrate its history as a secular institution that welcomed everybody. However, its history is much more complex than that. My dad and my mum's family are of Yoruba descent. Yoruba largest population is now in Nigeria. or what's now known as Nigeria. And he went to medical school at the University of Ibadan. And when he was training, he was very much told me, even when I got into UCL, that was a sister colonial institution, and the University of Ibadan was built in UCL's image, which a lot of people going there would never know. But that's a really important thing to understand about, particularly the European colonial process, that education was a key part of it, in terms of building educational institutions, initially for the colonial troops in that country, and then subsequently for the elites in that country, so that they could disseminate and help control, but also create countries in their image that adhered to British or French values. So I became familiar with the ties of UCL and its history to eugenics through my medical anthropology degree. So in my third year of university, where I was sitting in the theatre, the Galton Lecture Theatre, and I was informed that the origins of medical anthropology are a little bit dark. Essentially, it's a specialism born out of exploring the other, the colonized other, and trying to make deductions about the development and hierarchy of mankind. And Francis Galton, who is the founder of eugenics, had his first eugenics laboratory, and was given what was a substantial sum at the time, £20,000, to establish it there. So he had a laboratory where he'd measure the local population and conduct lots of his experiments. And this sent me down a bit of a rabbit hole, finding out more about eugenics and the history at the institution and how it continues to relate to medicine. In 2018, it actually emerged that UCL had played host to 3 eugenics conferences over the years, organised by some academics at the institution and others outside. And it's important to remember that although it's become discredited, particularly because of atrocities around Nazism, there's still a huge number of people that subscribe to the ideas of racial superiority, inferiority, and some people very overt about that, but it emerges in subtle ways. And I'll talk about that within family planning or sexual reproductive health as a whole. So who was Sir Francis Galton? So he was a very interesting character. He was actually the cousin of Charles Darwin. And that was actually also instrumental to him developing this idea. He was very committed to the idea that we could essentially eugenics improve the human species through selective breeding. And his final works, kept in the UCL collection, one of the collections now called the Eugenics Collection, Can't Say Where, he penned essentially his vision of a eugenic utopia in which people can only the people that have been measured in this laboratory and passed all of these series of tests are fit to breed and reproduce, and that will maintain the kind of best human species that will go on to develop. So that was his last kind of thing that he wrote, his major works. So if you view Galton's work through knowing about that, it becomes clear that very much a lot of his work was geared towards eugenics, and often he did so much work that people have pushed the eugenics to one side and think of it as an afterthought. But it's his largest contribution in terms of the impacts it had globally, and how it's resonated, particularly for colonised populations, indigenous groups all the way over. Britain didn't actually have eugenics policy, but there's eugenics policy when we think about the southern states in the US, in Australia, New Zealand. Policies were implemented that would restrict the reproduction of certain people based on the ideas put forward by Galton and then his protege, Carl Pearson. So Pearson was Galton's protege. He came after him. He took up the post which would be the first professional post of eugenics, now known actually as the professor of genetics at UCL, because the term fell out of favour. But Pearson was even more of a proponent of eugenics, and he was very much committed to anthropometry and the idea that we could measure people into these binary racial categories, and developed and very much developed what we now know as Pearson's coefficient, which lots of us use in statistics if we do population health or we do any kind of epidemiology and things like that. But that was very much derived from this idea of the coefficient of racial likeness, that he was comparing groups and he wanted to know how different how much they differed, and control for that so people could be neatly placed into these categories. So often it's disputed that eugenics actually was a racial theory. Particularly within British context, people say it was one of class, but it was one of many things. There's quite clear evidence when you look through Galton's work, Pearson's work, and lots of other eugenicists, but them as the forefathers, that was also very racialized, particularly conducting experiments on Jewish school children in East London, as well as Galton travelled extensively around Namibia. He would collect specimens, bring those back for analysis and so forth. And he really felt that mankind would be best if we could control for things such as racial degradation, criminality, which at the time was thought to be hereditary, people that were alcohol misusers, disabled, all of these things we needed to control for these populations. So after I went to UCL, I did my master's at the London School of Tropical Hygiene in Sexual and Reproductive Health Research. And this was, quite a few years ago now. And at the time, having these discussions about the colonial past of the institution wasn't really on anybody's radar quite yet. LSHTM was founded in 1899 by the Colonial Office and partly supported by funds contributed by colonies through what they were producing themselves and sent back to British administrations. And the idea behind these institutions, including the Liverpool School of Tropical Medicine, was that we needed to get a hold of infectious diseases, things like yellow fever that were killing troops that were stationed in the colonies and was impacting Britain's ability to successfully conquer these territories. So we needed to delve down into these diseases, find cures. And obviously the work of LSHTM has transformed over the years, and the dynamic is not so much one of that. However, when I went to LSHTM, and I now lecture there, so I say that as somebody that's still engaging and wishing to engage in this institution, because I do think it has a lot to offer. There were dynamics at play that showed that it had remnants of its colonial past. So what do I mean by that in terms of what research is done and for what purpose? In terms of investigating certain diseases is done because what is learned is transferable to a UK context or has wider benefits in terms of maybe trade or what we call development. Those people that tend to get grants or be lauded as experts are not necessarily the people that are the experts in these places where the research has been done and not necessarily appropriately credited for their contributions. And so we have to also bear in mind how these institutions continue to be shaped by some of this information. So my experience at LSHTM was very formative to me, again, thinking that some of these colonial histories are not just, they're also very applicable to my own context. As I said, I was doing a sexual reproductive health research degree, and I felt that a lot of the conversations about the legacy of eugenics, particularly within my own discipline, were completely absent during my degree, which I found quite striking, given the context of the institution. So when we think about how some people perceive, I guess, contraception, often this is just a smattering of thoughts, and I don't want to, get to do too much audience interaction because I think we might run out of time. But often the ideas that we get it's to help people plan their families. It prevents unwanted pregnancy. It helps to reduce medical complications in pregnancy. So if somebody had a previous pregnancy, they've developed a condition, using contraception gives them time between, to reduce unsafe abortion. Obviously, we know that a lot of countries still have masses of unsafe abortion, don't have the equipment. So rather than get people into that situation, we can negate that. It also has massive benefits in terms of controlling gynecological issues, heavy menstrual bleeding, anemia. I also do menopause care, helping people with menopause or symptoms as endometrial protection for when people are taking hormone replacement therapy. For some people, it can help with their acne. It can also prevent painful periods. And this is just a rough idea of like why contraception is deemed important. I'm sure some of you in the chat or others, please feel free to add some others. But there are many reasons why it has positive effects. However, there's also a kind of a different lens that we have to be mindful of how people view contraception. So to reduce abortion rates, and as I said, to reduce unsafe abortion is different. Some people feel that contraception is key because abortion's bad. So we need to negate abortion at all costs, and abortion is the worst thing that you can do. Obviously, as a provider, these things have to be weighed up between some of the experiences people have on contraception. And I have people that are very hormone sensitive and had, huge mental health issues just from changing different contraceptions and going on different contraceptions, and they don't have sex very often. So it's a complex conversation to reduce spending on abortion services. People don't want their money spent. Some people, children in care, children on welfare, to reduce child benefit, having lots of cases looking after them, to reduce pressure on housing, particularly in Britain, small country, or small, 4 nations, people increasingly saying that we don't have space, we're full up. So who can we give contraception to reduce the pressure on our services, our health services? Increasingly with climate change, more conversations about reducing pressure on the environment, reducing carbon emissions, part and parcel, a little bit of the same conversation. But how can we, reduce the overall footprint of as well? The idea that, we're kind of nearer our met need of contraception in Britain, but overseas, can we expand contraception there where they're not, to reduce the overall carbon emissions globally? To me, the racial, cultural, demographic of countries. So, people talking about fears about the white majority, particularly in European countries like Italy, that are having very low birth rates right now. People really concerned about migration and immigrants having more children than the population there, and what that does to the makeup of the country, and to maintain food security. So the same kind of conversations around climate change. We don't have enough resource to go around, so we need to use contraception to help with that. So the conversation around contraception is far more complex than people often give it credit for. And when I was doing my degree, certainly, we talked a lot more about the first slide and very little about the what I call the darker underbelly side, and maybe potentially what people really mean when they are implementing some of our family planning measures. So we've talked. Vinny already mentioned a little bit about Malthusian theories. So Thomas Malthus, his ideas have been quite central to how we think about population planning. So in 1798, he penned an essay talking about food supplies and population growth, and essentially said that population would eventually grow beyond the resources, and that would not be sustainable, i.e. overpopulation is kind of this inevitable thing. And we need to do something, put measures in place to negate this happening. Now, this has been kind of debunked in many ways, in terms of there are many things, as we know, that have impacts on population, whether that's kind of pandemics, whether that is climate. The population can change, and also quite key to this conversation is the idea of resource allocation. So obviously, if you look around the globe, we see that resources are not equally distributed, and this conversation obviously kind of just ignores that some person may actually be eating 10 meals a day, whereas somebody cannot get a bag of rice, which is kind of the status of the world globally currently. So it ignores this very central argument. So to just give a quick overview, we've touched a bit about Margaret Sanger's legacy, but often contraception, I think it's important to have a handle of the fact that there's lots of different key points of development, and this is just an overview. So in 1909, we had the first IUD devices, and often when we talk about long-acting contraception as kind of a recent invention, people have been trying to establish these for quite a long period of time. In 1914, we've talked about Margaret Sanger's legacy a bit already, so I won't delve into this, but it was quite a turning point in terms of understanding the birth control at the time, that's what Margaret Sanger used, was beneficial or could be beneficial in terms of eugenics, which I'll touch upon in a minute. Then in the 1940s, we started to get actually the early development of implant devices. In the 50s, we get the early combined oral contraceptive pill trials, which I'll touch upon, in Puerto Rico. In the 60s, the pill became available on the National Health Service, introduced by Enoch Powell. Lots of you won't know anything about Enoch Powell, but quite a key historical figure in Britain because of his infamous speech, Rivers of Blood, which not dissimilar to some of the speeches that we've seen coming out of UK politicians recently, to be honest. But he said something where he basically said that eventually the immigrant population will have a whip that they'll hold over the white man if we don't control for population. So it's also very interesting that the combined pill becomes available on the NHS free of charge in the 60s under his watch. But he was a complicated man anyway, so that it is interesting that he introduced those changes, because I think he also recognised that at the same time as encouraging immigration to support the National Health Service, that the pill could be used to kind of reduce the growth of certain populations. We get injectables in 1963, and then in 1970s we get oral contraception that's more widely available, not just to married couples, which was often the factor in Britain in terms of stopping it being accessible to everyone. Norplant was marketed in 1983. And actually, although it seems like contraception has stagnated, it's actually been one of the fastest moving areas of development in medical kind of innovation in terms of getting kind of new devices, sometimes not quite dissimilar to previous ones, but I think this is important to understand. So when we think about the legacy of eugenics and family planning, Frances Galton, who was at UCL, and I sat and listened to about my first medical anthropology lecture, really you'll notice a common thread. He was at the centre of so much of the thinking around population control and ideas around population that we have in terms of contraception interventions that we use today. So in many biographies for Mary Stopes, who some of you might know is the proponent of birth control in Britain and set up the first birth control clinic. We now have international organisation which changed its name, MSI, Mary Stopes International, named after her. She was actually anti-abortion but very pro-contraception. She met Galton when she was very young and was very enamoured with the idea of eugenics, and actually joined the Eugenics Educational Society in 1921. And I'll show you some quotes about from her, but she ardently penned about how birth control would essentially stop the growth of working class and racial degradation in this country. Very much like some of the views that Margaret Sanger echoed, who also penned the eugenic value of birth control. I would say that Sanger's views probably changed more, whereas Stopes was an ardent eugenicist, and that was quite central to a lot of her arguments and trying to get this movement to be bolstered. Somewhat just ironically, Mary Stopes actually went to the same school as me, and also went to University College London as well, which, again, I think is really important, because a lot of the ideas around eugenics, you'll find actually keep coming back to UCL as an institution, because there were people kind of silently working away at the institution around these ideas. So in her magazine Birth Control News in 1922, Mary Stopes penned Sterilisation of the unfit raises a hornet's nest, but no one worries at all about the daily sterilisation now going on of the fit. Young married men of the professional classes are today often forced by conditions to remain sterile, though they passionately desire the healthy children they could have if they did not have hordes of defectives to support in one way or the other. So this is just a sample of some of the things that she wrote. But in this quote, to summarise, she's basically saying we could use birth control to stop and lower the number of disabled people that exist that are dependent on young, fit, able-bodied men. And then we'd have a more kind of active working population. So here is one of the virtues of birth control. And these ideas, I would say, are not, they're not going away. People still echo them. I think a key way we saw this emerge is like during COVID, when actually the idea and Darwin's idea that Galton was very taken with, his cousin's idea of natural selection and survival of the fittest, was really at that core. It didn't really matter what happened to disabled and frail people because they weren't very economically fit anyway, and what a burden they were for the economy. So just a few more things to touch on. So when we talk about effectiveness of contraception, we often use something called the Pearl Index. This was derived by Raymond Pearl, another product of UCL's eugenics institution, partly trained there, and went on to pioneer population genetics and found the International Union for Scientific Study of Population Problems. Now, one of the key issues with the contributions of the Pearl Index and Raymond Pearl is that he was very much looking at contraception through this eugenic lens, that essentially the effectiveness of contraception mattered because the more effective it was, the more we could stop this degradation process of mankind through controlling for fertility of people that weren't contributing very much. And in Michelle Murphy's book, Economization of Life, she calls this the practice that differentially values and govern life in terms of their ability to foster the macroeconomy of the nation state, such as life's ability to contribute to the gross domestic product of the nation. And this was some of the starting point of this, that actually the fertility is clearly linked to development, and how can we control for this? So when we're thinking about family planning and we think of family planning in the context of population control and what people are talking about, Vinny's already talked about this. We're looking at the growth rates of populations and the idea that we can reduce the populations of people seen as a burden for a variety of reasons. And this is not exhaustive, but mainly people that are deemed intellectually inferior, physically inferior, mentally disabled. Historically, as I said, there was that idea of predisposition to criminality, although we see that as not a hereditary characteristic now. It historically very much was. The ideas of racial purity and resources and overcrowding and overpopulation. So just some examples briefly to illustrate some of the problems that have been historically. So Laura Briggs uses the example of colonialism in Puerto Rico and the trials of the early contraceptive pill on Onavid to talk about how that was first trialed in the poor provinces of Puerto Rico, led by Sanger and Harvard scientists, due to ongoing concerns around population growth. And it was chosen, this area was chosen as a place due to many reasons. There was a genuine need from that community. They wanted contraception because they were living in poverty and having unplanned pregnancies. This was exploited because there was a lack of oversight in that area, and people were willing to accept what we now know as toxic doses of estrogen. And there is evidence, clear evidence, that people died as a result of that trial due to things like thrombosis and things during the times of the trial. Obviously, the US and Puerto Rico still have a complicated colonial relationship, and very much they were those involved in the trial, after the trial was completed, didn't really have access to the more refined versions of that drug as well. So that's some of the starting points of contraception and our contraceptive history. When we look at the legacies of things like Depo-Provera, I'll touch upon it in British context. Depo-Provera actually ended up being banned in Zimbabwe. This is a bit of a complicated history, but in essence, it was initially being used, and particularly farm workers in Zimbabwe were wishing to use it again because they were in hardship, they were having to work, they didn't want unplanned pregnancies. However, they were being encouraged to take it by their white bosses because the government in Zimbabwe was encouraging people to use contraception because of these ideas of racial purity reduction of the Black Zimbabwean population. When the Black majority government came in to power in Zimbabwe, they actually ended up banning Depo-Provera because of that colonial legacy. Obviously, this negatively impacted some people that wanted to use it. However, it had this kind of torrid history, and they thought the best option would be to outlaw it. But it's important to understand that when we talk about Depo-Provera, so the progestin-only injection, that has a really torrid history in some countries. And if you roll out interventions or you're engaging with that topic, you're not going to get the same response that if you get to another country because of that legacy, because of that history. Lots of you will be familiar with the work of Dorothy Roberts, Killing the Black Bodies, and specifically looking at the Black US context. One of the case examples that she gives in that book is about Norplant and the use of Norplant in the US and some of the issues that happened when it was introduced. So that's the progestin, one of the earlier versions of the progestin-only injection. And that what was happening quite early on was judges and legislators were saying that we could tie contraception to people's specific sentences. So if you get an implant, then we're going to reduce your sentence, particularly for populations that they deemed the underclass. The Philadelphia Inquirer ran an editorial headline, "Poverty and Norplant, Can Contraception Reduce the Underclass?" So people actually were very openly, brazenly happy to admit that they wanted to use Norplant for eugenic style purposes, essentially. And because of this legacy and because of how it was perceived, particularly from African-American communities who were drawn in 2002, of course, we know the progestin-only implant is very widely available in the States still, as well as it is globally, because a different version came out, different versions that have come out and been renamed, essentially. But I think it's, again, an important example for showing, and also this idea that things get taken away and kind of repackaged at a more palatable time. And we've seen that again with Depo-Provera. So this links more to my own specific context. The Organisation of Women of African and Asian Descent was an organisation that was founded in 1978 and only lasted about 4 or 5 years. But boy, did they make waves in Britain whilst they existed. And very much born out of what was ongoing anti-racism struggles at the time. It was an umbrella organisation. They campaigned on a range of issues: immigration, deportation, domestic violence, exclusions. They did a sit-in around virginity testing that was happening, and lots of things, squatting, around poor housing. But one of the things that they worked diligently on was the Ban the Jab campaign. This quote is taken from Heart of the Race, Black Women's Lives in Britain, and this poster is in the Dadsey collection of the Black Cultural Archives. Sorry. The quote says, "Because we are considered a high promiscuity risk, Black and working class women are often encouraged to accept contraceptives involving less risk, but the reduced risk of pregnancy is invariably considered more important than the increased risk to our health." This idea that they were, particularly Black working class women, being offered the contraceptive jab, being offered or forcibly sterilised against their will, was clear evidence for. So the founder of Doctors for Choice, Professor Wendy Savage, actually conducted an audit in East London, which had and has at this time a large Bengali population, and was found that the Bengali women have given birth at the hospital there seem to be disproportionately getting given Depo-Provera after they deliver. It only lasts 3 months, as you can see in the poster, but it wasn't licensed at the time. It was off license, so people didn't really know what they were being given and the side effects they were experiencing. On this poster by members of OAD and other organisers, they've put they get dizziness, head botheration, depression, stomach trouble, severe bleeding, and obviously you can see the person in the picture looks like they're kind of unraveling. So there was a really consistent campaign over a number of years. And although Depo-Provera was eventually licensed in the UK, they attended the hearings. They did a lot in terms of making sure that it was not going to be rolled out without adequate kind of evidence, that it wasn't causing disproportionate harm, but also highlighting that they knew that was being given to people without due process and consent as well. So when we think about how people started to push back against these narratives, as I said, there's been a history of what is essentially reproductive justice campaigning in Britain within my own context for a long time. Often when we think about this sector, and very much the way that I was taught and came into sexual reproductive health, I was like, it's about choice, it's about people being able to be empowered to make their own good decision making. Autonomy, not having to be coerced. So we need to have clinics where people have time. There aren't people campaigning outside and things like that. However, the problem with choice, and I think marginalized voices have consistently reproductive justice as kind of a framework and term very much coined in the 90s by contributions of Black American women and others in the space that they were organising with. However, as I pointed out, this idea that that's just not good enough, particularly for marginalised voices, has been apparent and been said time and time and again, because for them, choice is not adequate because it omits all the wider structures that are governing their choices. How clinicians feel about them, whether clinicians feel that they should be reproducing in the first place, whether they have the resources to reproduce. So when we think about reproductive justice is a term was coined as the right to have a child, the right not to have a child, and the right to parent children we have, as well as to control other birth options, organising communities to address structural power and inequalities. And these were the guiding principles of reproductive justice. Individual organisations have, adapted this. An essential theme of reproductive justice is talking about power. This definition is taken from the Oakland-based advocacy group Asian Communities for RJ, and they say the complete physical, mental, spiritual, political, economic and social well-being of women and girls and will be achieved when women and girls have the economic, social and political power and resources to make healthy decisions about our bodies, sexuality, reproduction for ourselves, our families and our communities in all areas of our lives. And I think the political power and understanding where power lies in decision-making is really the key difference in terms of when we talk about choice frameworks, which essentially say, okay, well, if I give you everything you need, you can make a choice. Whereas when we talk about justice, we're saying actually that's not good enough because clearly the choices people are making are governed by so many other external factors. Is it really a choice if somebody doesn't have anything to eat, whether they choose to get a termination or not? That is not really a choice. It's a decision that they're forced into making one way or another. Or if somebody feels that, they've lost multiple children to police brutality or knife crime, is that really a choice that they don't really want to go through those hardships again? So the framing shifts. A lot of you will know about Loretta Ross's work. I think this is just really important quote from one of her papers where she talks about RJ as providing the intellectual commons of inquiry to impressively build bridges between activists and the academy to stimulate thousands of scholarly articles, generate new women of colour organisations and prompt the reorganisation of philanthropic foundations. And I think it has been really key to providing a gateway for these discussions between individuals that otherwise would not be able to exchange ideas. I think it's also important to acknowledge the limitations of having these discussions within some places. And understand that some of the work that has to be done has to just be done by communities themselves. A few last points. When we talk about decolonizing frameworks, I have multiple lectures I give just on decolonizing and decoloniality on its own. But this quote from Linda Tewa Smith, a professor in New Zealand of Maori descent, who wrote Decolonizing Methodologies several decades ago now, says to decolonize is to acknowledge the often harmful role that colonizations played in distorting knowledge and restructuring our society. Ask how we may dismantle epistemologies derived through colonialism, instead in center the experiences of indigenous populations. And obviously, when we talk about indigenous populations, we're also talking about colonized populations, not necessarily indigenous that plays, but at the heart of it. And at the start, someone talked about epistemologies and epistemic justice, and the idea very much that we've been told to see contraception and sexual reproductive health through this singular lens, particularly a developmental lens, that, you know, it has all these economic benefits, and that's why we should be doing it. I'm conscious of time, so I've only got a few slides left. So when we talk about taking a critical approach to the sector, we need to really think about the role that some of our interventions are having beyond our own local vicinity. How this might link to other issues that stakeholders face. These are just some of the questions you're asking yourself. Who else is this policy affecting? And very much like if any of you have done stakeholder analysis, this kind of thing, I think you know, we should all be doing that with any work we do within this area, and really delving down into how it might be perceived by communities. This is just a quick example about when I talk about critical analysis and how it applies. So this is a return on investment tool used by Public Health England for contraception provision. And essentially it was built about 3 or 4 years ago with the idea that, you know, £1 spent on contraception can give you £9 back in investment. And some of the things that they were looking at is like the cost to the system of birthing, of abortion, of miscarriage, of public spending on children, education, tax benefits, tax credits, lone parent households, maternity benefits, child in care, as I mentioned. And I think it's really hard when you're in this space and you've been taught about public health a certain way to maybe not want to do these kind of things. But at the heart of them lies the idea that essentially some people innately have more value by being birthed than others because they're not going to be an economic burden to the state. And out of the window goes rights-based arguments because they're not considered economically viable arguments anymore. It's not good enough to give or provide contraception because it improves people's quality of life outcomes or just improves their autonomy. You have to make a case based on how much you're going to spend in terms of tax credit. And whether we should be yielding to people political pressure to develop such tools, or whether as a sector we should actually say we're not doing this, I will open to the floor. I think people can probably guess where I lie on that spectrum. Again, we see similar issues happening when we talk about birth control in relation to rich and poorer countries, and I mentioned carbon emissions. I'd be unsurprised if it hasn't already happened, but we'll definitely get tools talking about contraception provision and offsetting carbon emissions soon. Again, you know, I've highlighted the problems with such narratives, particularly when there's not an even distribution of resource, and how very much when we look at Britain particularly, its own development happened through the Industrial Revolution, which was powered through slavery, and to expect other countries to be able to develop, but essentially without extracting huge amounts of wealth from elsewhere is possibly somewhat ridiculous. So often these conversations are had without nuance, or without kind of just in a vacuum of history, which is obviously deeply concerning. And just to point out a few things that people should be aware of. So when we talk about race and colonialism, its relation to contraception, the family planning sector, we also see people, when I'm having these good discussions, people seeing what I'm saying and they're pivoting, but they're also taking certain things on board. So we've seen in recent years with El Paso and Christchurch mass killings, manifestos about immigration and environmental warfare, and how untapped immigration is leading to lack of resources, and the degradation of countries. And we have to be mindful of feeding into such narratives by these arguments around contraception and carbon emissions within our own sector. We also find that people using arguments like that of the legacies of individuals like Margaret Sanger to say that, okay, the only reason we have abortion clinics in Black neighborhoods and things like that is because people are trying to control for Black populations and things like that. So at the same time as highlighting these histories, these legacies, the real atrocities that have been committed through use of family planning measures, as guises of population control, we have to be mindful of the fact that people can also misuse those histories to then say, actually, this is why we shouldn't provide these services for very different reasons. So we see this with organisations popping up like Black Preborn Lives Matter, and other organisations such as this one, Pro-Black, Pro-Life, and talking about how we should not be supporting this sector because they're inherently anti-Black as well. So I think people need to be mindful of how the conversations can actually end up pivoting elsewhere. If anyone's interested to know where you are in the world, but this is my book. I talk about some of this in the chapter They Call Me Jezebel. And I also just talk about the colonial history of eugenics and generally across healthcare, mental health services and everything. So anybody wants to read it, it's by Wellcome Collection. It's published by Wellcome Collection, who actually, on this vein, have actually shut down their own exhibition recently from Henry Wellcome, who had collected lots of colonial trinkets in his years, including figurines from the Yoruba tribe, which I saw in the collection and responded to, in terms of we got to respond to different items. And so a lot of organisations are starting to do work and grapple with this history, and how we grapple with it is somewhat challenging, but trying to be part of that conversation. Thank you very much, and sorry, I think that was a bit longer than I'd hoped.
Thank you very much for that very in-depth and expository presentation. And from my end, I am listening to you and going through this course of history and asking myself that how has all of this shaped the current trend, and what kind of engagement would I want to consciously be involved in to challenge and to maybe engage when it comes to my history and the population dynamics around it. So thank you. We are really running out of time, but we have a few very interesting questions, some of which I think our speakers have addressed, but there's still a few that would be great to hear your perspective on. I'm going to read some of them, and any of the speakers, please feel free to respond. We have a question from Amelia, and Amelia is asking, she has two questions, but one of her questions is on climate change, climate change, contraception, and the current narrative on it. She wants to know what your perspective is on, and if you think it's tending towards population control or making the environment green or climate protection, as the case may be. Then we also have another question from Amber Clegg, who is working at LSHTM. She would like to know how these narratives and the neoliberal movement agenda and practices, how it can be pushed forward in terms of the student body, right? And she would like to know what are the critical social science perspectives that can be applied in this respect, and if we are able to apply this perspective widely. Then Sarah has a question on how we can get more of this conversation, and not just conversations, but actionable points and outcomes coming out of these conversations on power shifting between the global north and the global south. I would give room for the speakers to respond to this question, and if there's more time, we'll get into other ones. Thank you. Anybody, Dr. Annabel or Dr. Vincenza, please go ahead.
Okay, so I'll go ahead, Amelia, and address some of your question. I would very much agree with you. I think what we're seeing is this kind of materialization of arguments that were made in the US, specifically through the World Bank in the 1960s and 70s. And I'm thinking specifically about the book, I believe it's called The Population Bomb, right? Which argued that the environment, in order for its preservation, that population decline was necessary and that specific measures needed to be put in place. One of them that was recommended by the author was something called adding sterilids to water to keep people from reproducing. And what I would suggest is that new work done by scholars in anthropology who work specifically on the Anthropocene are leaning heavily into ideas that Annabel has already explored that aren't about population and environment specifically, but are about consumption patterns and the abuse and neglect of the environment following the fourth stage of industrialization. So I think it's a way in which land is being used and the overconsumption by some populations in the global north, specifically in the US, that have quickened the rate of climate change. And again, people or scholars who are working on the Anthropocene are publishing work in the field. I'm thinking of the work of Julie Livingston, her book by Duke University Press called Self-Devouring Growth. She works on the case of Southern Africa and talks about cattle and industrialization, how new kind of enterprises around capitalism and food production are driving climate change. So I think that's one way to think about this as a repackaging of the same neo-colonial ideals within what you're calling the green wrapping paper.
Thank you. Annabel, do you want to respond to other questions?
Yeah, I'll just say on that topic, that was really thorough. Essentially, I would look also at the work of Anne Hendrickson and the Collective Power for Reproductive Justice and what they're doing around talking about environmentalism and framing and things like that as well. In terms of the question, I think there was one around being at LSHTM and teaching critical approaches. So I lecture on the family planning and also the sexual health module. And of course, I'm just one person, that's just one lecture. I've been invited there by the course conveners. I do lecture at a lot of universities in London on various different courses. I think most institutions have been very receptive about it. I think what's really hard, and even in my day-to-day job, as I said, you know, I'm about to be a consultant, I plan services. People expect me to use things like that tool, right? That's how I get funding for my clinic. It's whether people are bold enough to say, no, thank you, I'm going to try and do something different. And because at the end of the day, employed, people want to get their fellowships, they want. When you become more senior in your role, I think, you know, my supervisor, my PhD, very supportive. Clinically, I'm much more senior than I am academically. How can I support people that are trying to do those things, be a co-supervisor for people that are on clinical academic pathways, for example, to develop those innovations, or be a supporter whilst they're a PI on a project, for example, that is actually going to do that work. And I think that's really important as well, because I do think people want to do the more boundary pushing, like, okay, we're not going to use that tool. I'm going to do something that can be more rights-based, that clinicians and others can use to make this argument. But it's really challenging to get the support around that, you know, and get the people that can support your funding and things like that. So I'd say the institutions are receptive, but it's everything else has to follow. You know, funders have to follow, the supervision has to follow. You know, the engagement with the right organizations and communities also needs to follow. So it's all the other bits as well. I think that's challenging.
Great. Thank you so much for that response. I'm going to quickly address the question Sarah asked about how to better engage global North and global South actors in this conversation and get actionable points. I would say that for power shifting, there's a need for continuous pushing. And every platform you get, you have to push these conversations. With the work we have been doing at the Power Shifting Subcommittee, we have individuals and institutions who have some of these historical leanings on colonization and also the power dynamics that they hold, but then they are holding themselves accountable to say, how can we do better? And we have utilized platforms such as conferences, summits, and also collaborations. Currently, we have the Shifting Power in SRHR Community of Practice, which has over 700 individuals and organizations they are affiliated to, sharing resources, talking about the practices they are involved in, the challenges they're experiencing, and getting support to share and shift power. So my point exactly is that it's not going to be easy, that they need to keep pushing. And in all of these meetings and convenings that are held to have this conversation between the global south and the global north, is you need to define the agenda from the place of honesty, from the place of speaking truth to power, and from the place of being willing to listen, to step back, and to step up. So those are very important. There's also a need for alignment in a shared vision, because in many of these meetings, I ask myself, how are we not colonizing this decolonizing global health agenda? Because I hear it a lot and I'm like, do you just want to tick the box to say you are decolonizing using the word, or you're also colonizing this agenda? So these reflections are important, the stakeholders you're involved with, and continuous pushing to get those results that we want to see in the long term. It's a journey, no doubt, and we hope that in that journey, we can also track the progress we are making, highlight things that are working, so that it can be a useful reference point for others who are struggling to understand how to do better. And on this point, I'm going to deeply appreciate my amazing speakers. Thank you so much, Vinny. Thank you so much, Annabel, for having us. We deeply appreciate. I will definitely grab your book to get more insight on what you have shared. And if you all, I want to encourage you to do same, read more about our speakers. And like I said, my biggest reflection from these historical legacies in population health is, how do I immerse myself into these histories more, to understand it, and to also use them as a reference point in reflecting and analyzing the kind of engagements I get involved in, the institutions I find myself, and challenging the power dynamics that exist, and mobilizing forces for us to demand for more equitable engagements and practices. Because if you do not know your history, you will not be able to engage better. You will not even know when your rights are being trampled upon, on when some of these nuances are based on maybe colonization variants. So I hope that from your end, you're able to get these reflections, and I want to encourage every one of us to join us in our second webinar series. This will be happening on the 30th of November, and it will be so robust, in the sense that we want to hear from the actors in the field, from individuals, organizations, to share their power shifting story. How are you shifting power in practice? What are the challenges you're experiencing, and how can we do better? So we have a lineup of individuals who are willing to share this with us, and at the same time, it's also open to the discussants and participants who will be joining to also share, reflect, and very importantly, commit to equitable engagement and practices in population health. I want to thank the IAPHS team for giving us the opportunity to host this webinar, and appreciate the ICFP Power Shifting Subcommittee for pulling through on this against all odds. As mentioned by the IAPHS team, the recording of the session will be shared with all the participants, and you can also find this resource on the ICFP Power Shifting Subcommittee website. And if you also join our community of practice, you can also get this resource soon. Once again, thank you for joining us, and I hope that you have a restful evening or day ahead. Thank you.